And I've had several questions come in, just, as soon as the class opened, as about what electrolytes we are studying. We're gonna concentrate on sodium and potassium, because that's where our water balance stays between our cells. The intracellular and extracellular fluid is controlled by potassium and sodium. We're gonna touch on calcium and magnesium, but our full focus is gonna be on sodium and potassium. Did you guys get a chance to look at the videos that were on there? They had a lot of information, a lot of refreshing stuff that you've learned before, but it's kind of refreshed your memory a little bit when it comes to fluid and electrolytes. Fluid and electrolytes have an effect on all parts of our body. Our elimination. How does that have anything to do with elimination? What?
How much you pee?
How much you pee, right? How about food? Can you poop without water? No. So your elimination depends on a good fluid and electrolyte balance, yes? And when you do eliminate, you have to take in to replace that. Right? Everybody's good on that part. How about the acid-base balance? You don't know a lot about this right now. You'll learn about more next semester. But in order to maintain that that acid-base balance, you have to have a fluid balance. You have to have a complete balance in your fluids. Fluids coming in, fluids going out. Gas exchange also. How about perfusion? Can you see how perfusion would be affected by your water balance and electrolyte balance? Hormonal regulation, cognition. You cannot think straight if you're dehydrated or overhydrated. Your brain is not going to function the way it should if you don't have a complete balance in the water and electrolytes. Oh, and mobility. Let's not forget about that. Can we move around? When you're sick and you feel dehydrated, you haven't taken in enough fluids, or you're vomiting, you have diarrhea, how's your mobility? Speak up. It's weak and slow. You don't have the energy to move around like you should. Can you have proper elimination if you don't have proper mobility? You cannot. No. People that are bedbound, they have problems with elimination. They have problems with intake. So this water balance, this fluid and electrolyte balance you just have to have it in order to operate, your body to operate the way it should. How do we keep the water where we want it? It's with osmotic pressure between the intracellular and the extracellular fluid. It's an exchange of water and sodium and potassium. Where is sodium more prevalent? In the extracellular, right? Does that mean there's none in the intracellular? No, there's a little bit in there, but most of our sodium is on the outside, and potassium is inside. There's also a little bit of potassium floating around in there. And that osmotic pressure, that gradient that goes back and forth, is what keeps our water balance in our body. Right? Y'all remember this from somewhere in your past lessons, right? Okay, don't let me run it into the ground, but you gotta know how that is balanced. Can your electrolytes just travel freely between the cells? No, they cannot. They cannot, but water can. And for the rest of your life, remember, water follows sodium. So when there is a bunch of sodium, our water in our body is going to travel to that area until it's equalized, that sodium and water on either side of the cell. Right? So keep that in mind. If you have a question or you have a comment, please speak up. All right? I don't want to speak the whole time. See? That's the thing about lecture day with us. It's like, God, do we have to do everything in this house? No. We want y'all to help us. All right. So this little picture kind of looks at the intracellular and the extracellular fluid, and it gives you a breakdown of it. But you're pretty familiar with this, yes? Yes. Is it something we need to go over in depth? Somebody say yes. How in depth do you want to go? Which part of it is not coming clear? All of it? What?
What do we need to know for the exam?
Right? Okay. What do I need to know for the exam?
All of it.
For my part of the exam, you need to know that I'm not going to tell you what you need to know for the exam. That's a good one. That's easy. That's probably the easiest part for me today. That's not my job. Have y'all ever said that? That's not my job. My job is to make you think. My job is to open up that nurse brain and let those little voices that you hear here in your head come out and answer your questions. All right? You have your objectives. Everybody's seen the objectives, right? That's in the beginning. Everybody has that? For my part of the test, you need to be able to look at these objectives and know what the objectives are. Be able to answer these objectives in your own words. Because I'm giving you this in my own words. I write them down everywhere. I don't type my lectures. I don't copy and paste my lectures. They're all handwritten in my notes. That's what I expect from y'all. Because I'm not going to expect anything from you guys that I haven't done or that I'm willing to do. So I prepare for a lecture when it's my turn, and I want y'all to also. Is that a good answer? I don't want to offend anybody. God knows I don't want to be called to the principal's office. And I will be called. But yeah, I love you, Chris. And I love your forwardness. I can count on you. All right, so we're moving, right? What do I need to explain about this slide or about the process by which we keep our water where it belongs? Yes?
Okay, so water follows sodium.
Always. Water follows sodium.
When you have high levels of sodium and the water follows, that's where you get it.
Exactly. Because that's where, she said where if the water is going to that place where a high level of sodium is, we're going to get some edema. If we're not able to move that water off. Right? Everybody sees that. But in a wonderful working machine that our body is, if it's functioning properly, we should be able to take in that fluid, use it wherever it's needed in the body, and then get rid of it. Right? Okay, good. I like it. Does that answer it? Good. Okay.
You said osmotic pressure.
Osmotic.
Osmotic.
OS.
And that's
Osmotic. Think of osmosis. What What is osmosis? Right, from, the water moves from a lower concentration to a higher concentration. Water is what travels through that cell membrane easily, that's osmosis. All right, anything else is called like active transport or something like that, where we're actually trying to move the molecules or the electrolytes out of the cell. That requires, an active transport. It requires a carrier of sorts. All right, so osmosis is the travel of water from a lower concentration to an area of higher concentration to where it can make it equal.
So it's the same thing.
What, the same thing as what?
Osmotic pressure.
The osmotic pressure is what holds that. The sodium is here, or the potassium is inside the cell, sodium is outside, and that pressure gradient between them is what makes that equal. Ah, good. I love that. Oh, that gets me excited because I've answered a question good. Sometimes that's hard for us up here. You know, and we depend on you to let us know, like, wait, you're not reaching me. So I really appreciate that. Any other questions about this slide? Yes?
Just to clarify, so for the osmosis, I have the definition of just like the fluid being moved across the cell membrane.
Right.
And then for diffusion, I have particles moving from higher to lower.
Mhm.
And then active, I have lower to higher. I don't have anything about the lower to higher for osmosis.
Yeah, that's the movement of water between that cell membrane. Water is the only thing that can move by osmosis through that membrane. Everything else needs a diffusion or an active transport or something like that.
Okay, I just wanted to clarify that it's like the balancing of water and not like the higher to lower and the lower to higher.
It's the balance.
Okay.
Yeah. Good. Okay. It shows you where the water is. It's in the lymph system, cerebral spinal fluid, the GI, blood and plasma, synovial fluids, and the pleural fluids. We're going to be on that cellular level. When we talk about sodium and potassium, we're on that cellular level, all right? Because we can't just, the way we get those sodium and potassium levels is through a blood draw. Right? We can only get that through a blood draw. Now we can anticipate a lower or higher sodium or potassium level if our patient has had diarrhea or vomiting, or maybe he or she's got an NG tube because we're disturbing the balance, that acid balance in the GI tract. With the vomiting and the diarrhea, that's also getting rid of, you not only get rid of the vomit, but you're getting rid of your electrolytes too, right? The water and electrolytes. So when something like that is happening with our patient, we can anticipate a rise or fall in those electrolytes. All right, and then we do the blood draw. So I just want you all to understand, we're just not gonna reach in the gut and, see if we have a high or low potassium or sodium. We're gonna have to actually do a blood draw. But we know we're gonna do that blood draw because we've assessed our patient. True? Good. Oh, y'all are good this morning. Maintenance of physiological balance of body fluids. An optimal balance for our body fluids depends on volume. You all need to know this. It depends on volume, osmolarity, and the electrolyte concentration. Those three areas is going to give us our balance, our optimal balance. There's three areas that that are gonna give the optimal balance, our optimal water balance, water electrolyte balance. That is volume. Do we have enough volume in our system to carry our blood electrolytes? Osmolality. Is our fluid and electrolytes equal? And then the electrolyte concentration, where if there's a problem, which electrolyte is it? All right? Does that make sense? Good. Intake and absorption. Anything you take in is gonna have an effect on that water balance. Food, your air, your water. It's gonna have an effect on the fluid and the electrolyte. And their movement in the body. If you don't have enough volume to move these electrolytes, they're really not much good, right? And you're gonna end up sick. Right? If you don't have enough volume, you've lost the water volume for whatever reason. Are your electrolytes and what's left of that water volume higher or lower? Who's that higher? Ding, 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 ding. They're gonna be higher, because they haven't changed. You've lost the water that you had that optimal flow with, so now your water has decreased, but those electrolytes are staying the same, right? So that makes their concentration higher than it was with the water, right? Everybody say right or wrong? Right. Do you understand it? Do you understand why it's right?
I guess usually like we excrete electrolytes if we want or have diarrhea, so how come it stays the same?
Because we can lose volume in different ways. We're talking about the blood volume, remember? When we're vomiting and having diarrhea, it's gonna affect our volume in our body. But remember, we're on that cellular level. So say we've lost volume at that cellular level, but the electrolytes are still there. So you see how the electrolytes would be heavier once we take the water out? Like coffee. Who's a coffee drinker? Coffee drinker? All right, good. What makes a good, strong cup of coffee? More coffee, right? And less water. So, what makes a weaker cup of coffee? More water. We add more water. So if we don't have a full volume, right, at our cellular level, our volume has dropped, maybe we've been injured, maybe we're bleeding inside, we're losing blood out of that vascular area, then our electrolytes are going to be higher in that. We're going to expect a higher level of sodium or potassium because we've got a shrunken volume. Yes? Okay. Distribution, process of moving the fluid. How much water do we have? How much is that fluid moving? And then output. You have to look at that, output. Removal of fluid and electrolytes from the body from normal and abnormal routes. Normal would be our urine and our feces. Abnormal would be if you got stabbed or shot or, and everybody's doing a lot of shooting. Did y'all hear about the parade? That was just ugly. That was ugly. But everybody's getting shot, right? Questions about this? Maintaining that fluid volume. Everybody knows what fluid volume we're talking about, right? What? That was a yawn. Oh gosh, I'm losing them. So understand that any disruption of intake and or output leads to an increase or a decrease in distribution that can impact the amount of that amount of water balance. Any disruption. All right? The most important fluids to keep in balance. We've been talking about them, right? What's in the cell, what's outside of the cell. If you can keep that balance there, and keep that water moving the way it should, keep our volume up, everything goes smoothly. Changes, especially decreases, may lead to poor organ perfusion. Think about that statement for a minute. Can you all see it? And in my brain, I can see it because that's how my brain works. I wake up in my own world every morning, my own private world, and when I talk about fluids and electrolytes, I can see that vessel just moving. The water's moving, my electrolytes are doing good, but I can also see when we lose our volume, how hard it is to push that little bit of volume through this big space. Do you see how hard that would be? The heart's got to pump that still. So when you lose volume, is that gonna work? Is that gonna make your heart work harder? Right. Because you have to go through a bigger space with a smaller amount of volume. Look at the other side of the coin. Now we have tried to correct our patient's volume issue. We've given them tons of IV solutions. We've diluted everything out, right? And we have this huge amount, this huge volume of fluid pushed through those vessels. Is our heart going to work harder? Do you see that? Everybody sees that, right? So any disruption in that distribution or that volume is going to have an effect on our heart. It's going to have an effect on our breathing, our breathing. Why is an overload of fluid, how's it going to affect our breathing? We're not perfusing, okay? What else? Lack of space, okay, and what else? It fills your lungs, doesn't it? With what those alveoli fill up with water, fluids. When I talk about water, I'm talking about fluids, okay? I use these terms interchangeable, but it's the same thing. How easy is it to breathe in water? It's not. Trust me, I had an episode, a respiratory episode, when we had all that freezing temperature. Never had a respiratory problem. Folks, when you cannot breathe, that is scary. That is scary, scary, scary business. And nobody can get to you fast enough. And if you're my age and you can't breathe, and you go to one of those acute care centers because you need help now, they're going to send you to the ER because you're too old. They told my daughter that. They tried to whisper. I could not breathe. I waited till she got home. I called her at work. I said, listen, I cannot breathe. I think I am sick. Will you take me to the doctor tonight? Here we go. Well, those access medicals will be out there quick. Give me a breathing treatment. filled out all my paperwork. I couldn't even breathe to do my paperwork. I was like, I can't breathe. She filled out all my paperwork. Rush came and sat down. And the lady up there, little girl, I mean, she's so young, maybe 20-ish, so young. And she's trying to whisper to Rush, she says, because of her age, and she can't breathe, you need to take her to the ER. And I said, I told Rush, I heard that. They called me old. Yeah, you cannot breathe if you have so much pressure, maybe from the water or whatever. That is scary, scary. Even though I know in my mind I can breathe, I was talking. You can't talk if you can't breathe. But still, it's a very frightening thing. So keeping that balance will help your body from poor perfusion and cellular disruption or dysfunction. Okay? Electrolyte distribution. We've kind of been talking about that, haven't we? A little bit. God, there's a lot of notes on that one. Y'all need to get ready. 3 main functions of sodium. The 3 main functions of sodium. Yes, I'm old, but I repeat myself so you'll know that I mean it. Alright? And there's a reason I mean it, is because I'm not going to say, Chris, this is going to be on your test. But I want you to be able to follow me, okay? The 3 main functions of sodium. Maintaining blood pressure. Does everybody see how that works? Maintaining blood pressure. You have to have that water balance, don't you? That fluid balance. It has to be good. Maintaining blood volume and a pH balance. Okay? And what I say about water, it always follows sodium. Always and forever, water follows sodium. So if you have a high concentration of sodium or a high concentration of whatever, but mainly sodium, that water is going to flow to that area and try to equal it out. Hypernatremia. Now that's one of our terms, isn't it? Hypernatremia, which means what? High sodium, hyper. Anything hyper is high, right? Hypernatremia equals big and bloated. You can read more about that on page 261 in your book. Your late and serious signs and symptoms are swollen tongue, GI, nausea and vomiting, increased excitability in tissue, or irritability is called. Increased excitability in the tissue, also called irritability, especially in the nervous system and the skeletal system. Nope, the third one was pH balance. I already passed that one. Did I lose you? Okay. Well, we're back here. The 3 main functions of sodium are maintaining blood pressure, blood volume, and pH balance. Alright? Then we were talking about hypernatremia equals big and bloated. Big and bloated, everything's big or extra, like the excitability of your tissues or the irritability. It's magnified. A sodium level higher, with the sodium level higher, the water is going to move to that area, right? The water moves from the cells into the extracellular fluid, to dilute the hyperosmolar extracellular fluid. All right? And this causes severe dehydration and cellular shrinkage. If the water's moving out of the cell into that area of higher concentration of sodium, which is outside now, so the water's moving out of the cell, what is happening to that cell? It's shrinking now. All right? So hypernatremia, you'll have dehydration. If your patient is dehydrated, they've probably got hypernatremia, right? Because we've moved the water, which is caused the concentration of that sodium to become higher in what's left, right? Everybody get that? Is that an easier connection to make now? Okay. I'm all about finding those easier connections, like making my brain connect, saying how to remember that. So your assessment with somebody like this, hypernatremia, you know that the cells are shrinking, maybe your patient's dehydrated, but we know that our patient has got a lower fluid volume for some reason, right? What might we assess in this patient? Skin turgor, right, skin turgor. And I'm gonna go straight into something else, which I'll probably repeat later because it's in my notes later. Skin turgor. We always thought about doing it like this, right? Off the back of our hands. Is that gonna work with our old people? Not me old, because I'm not that old. My turgor is just doing fine. Well, what happens to the turgor in our really old people, our older population, which are more prone to this, they're at higher risk for dehydration? What happens to that turgor on their hands? It stays up. Why does it stay up? Loss of elasticity. Exactly. So do we really want to depend on skin turgor from the back of the hand on the old folks? How about our babies? Because they're at high risk for this too, right? Their bodies are smaller. We don't want to do that either. No. So, skin turgor is a way we can determine our hydration, but we're going to do it off the chest. Right from the sternum. All right, that's a better indication. However, now remember in nursing school, you have multiple choice questions. All the answers are correct, but only one is more correct. In this case, that's what this is. Because turgor, checking the turgor on the sternum is good. But the gold standard is going to be daily weights. Daily weights. Daily weights, folks. Daily weights at the same time, every day, preferably before breakfast, on the same scale, with the same clothes on. Daily weights at the same time, preferably before breakfast, on the same scale, with the same clothing on. Daily weights, that is the gold standard of hydration status. Although, pinching the sternum is also better. This is one of those questions that you might have all four of those options, but by reading the question, you'll be able to pick the better of the four. All right? Daily weights. How many pounds in a kilogram? 2.2. 2.2. In your book, it says, if you're telling a patient what to look for, if they're being discharged, or you're trying to explain the daily weights to them, you would tell them a gain or a loss of 2 pounds in a 24-hour period would signify a water balance or water imbalance of some kind. If they gain 2 pounds or more in 24 hours, they may have a fluid overload, right? Yep. Any of your patients that are on a fluid restricted diet, or maybe they have congestive heart failure, or they have some type of other edema issue, a water holding issue, they'll use this daily weight to see how severe it is. But just know that a gain, and you tell your patients a gain of 2 pounds or more in a 24-hour period could be a sign of fluid overload, or a loss of 2 pounds or more in a 24-hour period could be indicative of what? Dehydration. Say it like you mean it. Y'all know stuff. All right? Do you see how this is just it's playing on opposites? If you know one, then you know the other. It's just the opposite. Right? So if you're going to assess these people, you're going to do the daily weights, of course. Yes.
Do you have to be careful with that, especially with patients like diabetics, with that term? Because essentially, if the patient is like on like a Lasix at home, they could lose up to 1 to 2 pounds throughout the night.
If they're supposed to be.
If they're supposed to.
If they're supposed to be, yes.
Okay.
Yes. But with that person on Lasix, did everybody hear what he said? That a person on Lasix, may lose those 2 pounds? That's an expected effect. That's what we want to happen with Lasix. We want to pull that water off. But how about if that patient on Lasix is gaining 2 pounds or 3 pounds overnight? That's not good, right? Because that means the Lasix is not doing the job that we want it to do. So I'm glad you brought that up. Do y'all see what's happening there? So yes, you have to be careful. But if your patient's on Lasix and you're giving them directions for home, you'd say if you gain pounds, if you gain weight overnight, you need to talk to your doctor because the Lasix is not doing what they expect it to do. Good point. Thank you. All right. So how about, is our brain going to be able to function properly if we have too much water floating around? No. Because all of our electrolytes are diluted, right? We have too much water and not enough electrolytes. And we need electrolytes to properly function. Our muscles need electrolytes. Our heart muscles need electrolytes. Our lungs need electrolytes. So do you think we might see some confusion in these patients with a water imbalance of any kind? Even if it's dehydration. They're not getting enough water to the brain, so they become confused. They may have a short attention span. And that doesn't mean people like me that have raccoon syndrome all the time. No, these people have been normal, and then all of a sudden they have a short attention span. They can't remember. They become confused. What happens when our people become confused? Do they become agitated and combative? So if our patient is just this great person all the time, and then one morning or in the afternoon or whenever, they become combative and mean where they never have been before, do you think we should be thinking about a water imbalance of some kind? I think so. So we're going to look at their mental status. Yes.
Is there a difference between being confused and having altered mental status?
how you use them. All right, so like, you're perfectly fine right now, but you fall out of the chair and you jump up and say, oh, I'm okay. But we all seen you hit your head, and then a little bit later, you start acting kind of weird, altered mental status, right? Confusion, your patient is not taking in fluids like they should, and they're normally very nice and very easy to get along with. And then all of a sudden they become this confused, combative type person because of the water loss. Right?
So do you think they're kind of like, let's use the same example, alternate status being something happened, like falling into the head.
Maybe.
Think your mental status is altered.
Right. Right. Okay, so then on acute fluid overload, our patient may still be lethargic. And they could be stuporous, and they could end up in a coma. All right, so assessing that mental status, more normal or decreased fluid volume, may have short attention span, become agitated, confused, whereas the fluid overload, the patient may be lethargic, stuporous, and comatose. Right? Questions about hypernatremia? 261. 261. Iggy. Yeah. Normal values of sodium. My slide says 135 to 145. Iggy says 136 to 145. So 1 point is not going to be enough to affect anybody's thinking on an exam. Because if we give you a range, it's going to be out of range. It's not going to be 1 point. You're not going to be able to put a query in there saying, okay, you said 135, and this one was 130. So there's going to be a big enough span in that range to where you'll be able to pick out whether they were hypernatremic or hyponatremic. All right? Just clear that up. All right, any questions about hypernatremia? Where are we? Oh, we're doing good. So hyponatremia is just the opposite. Page 260. On page 260 of the with hyponatremia, if hypernatremia was big and bloated, what do you think hyponatremia is? Small. That's a good thing. It's flat. It's deflated. Hyponatremia, not enough of. Alright, so then now everything's kind of depressed and deflated. Right? Hyponatremia makes depolarization slower. I'm not going to get into the heart with y'all and a lot of strips and rhythms, but trust me, if you, once you learn rhythms, you'll be able to look at a strip and see the difference between a T, a spiked T wave, or a U, depressed U, or PQRST. You'll be able to see the difference in these. Okay? So just know that an EKG of hypernatremia, the spikes are going to be sharp and high. For the hyponatremia, all of PQRST's things are going to be low and deflated. They're not going to have those nice sharp points. All right? Be low and deflated. Osmolality of the ECM HCF is lower than in the inside of the cell, right? So excitability membranes are less excitable. All right, they're not hyper excitable anymore. It takes more of a punch to get them to respond. So how are our muscles gonna be? How would you think our muscles would be with a hyponatremic state? Slow to respond, right? Slow to respond. This movement, that osmolarity movement, is gonna cause the cell to burst, because that water is moving now from outside to the inside, right? So it's moving, and the more water that gets in there, just like a balloon, it gets bigger, bigger, bigger until it bursts. Can our cells carry oxygen like that? No. So are our brains gonna work? Well, in that same state, say it like you mean it. No, it's not. Our muscles are not gonna contract as well. So with hyponatremia, our assessment's gonna include behavioral changes, and that could be from cerebral edema, right? Cerebral edema, does everybody understand that term? I can't stress enough how important it is to know your key terms. Know those definitions. All right? We're also going to assess level of consciousness and cognition. Cognition, what does our patient understand? Do they understand anything of what's going on? All right? When we first go in to introduce ourselves, or anytime we go into our patient's room, we ask, can you tell me your name and your date of birth? Sometimes we get more intense and say, do you know where you are? Especially if we have an inkling that they may have some cognition problems. Do you know where you are? Do you know why you're here? They can't answer those. Do you know the date, day of the week, the month, the year? Make it simple until we can figure out where their cognition lies, okay? Assess a sudden onset of confusion. Any sudden onset of confusion should be investigated further. There's a problem, folks. If your patient is fine, and then all of a sudden they become confused for no reason, think of water balance. Even with these old people, you could think UTI. Is that a problem? Yeah, it is. It is. So you're going to assess their mental status. You're going to see some general muscle weakness and diminished deep tendon reflexes. We talked about diminished muscle response, right? Increased motility in the gut will cause nausea, vomiting, and diarrhea. We've already got a water issue, right? So that's the last thing we need for our patient is to start vomiting and diarrhea, right? So with that, we've assessed our mental status. How are we going to know if they're having a problem in their GI before they try to get to this nausea and vomiting part? What are we going to assess? Bowel sounds. And what are we going to expect from those bowel sounds? Hyper. All right? Because there's increased motility, and you hear those bowel sounds starting to really talk. Think, oh man, maybe there's some nausea going on here. Maybe we need to be proactive because we may get some vomiting or diarrhea or something like that. We're going to have a rapid, weak, thready pulse. Rapid, weak, thready pulse.
And that's with hypo.
Hypo. Hypo. questions so far? Hyper and hypo, out of the way.
What do you mean by thread?
You can barely feel it, it's rapid, but it's thready, it's like going fast. You know, barely feel it, but you can feel it, it's fast. What if you had a really bounding pulse? Just think of that pulse just bounding. What might you think about that? Would that be maybe fluid overload, or would it be too little fluid? Bounding, really pushing, overload, overload. Why is it so strong? Why is it bounding? It just boom, boom. Why is it doing that? And you have too much fluid. It's fighting to get through that fluid. You have a weak and thready, and then you have that bounding. I love fluid electrolytes. You just get to be so animated. Doesn't matter if you can dance or sing, you just get to, there it is, there it is. Do you think you need a break before we get into potassium? Probably. All right, let's take 10 minutes.